There you go. It's recording.
Great.
Yeah. So I get just an introduction. Dr. Jason's my advisor here. He's been at DePaul for over 40 years. Is that right, Dr. Jason? I think we celebrated.
This is my 47th year.
47 years. It's been around. I mentioned he brought in the biggest grant in DePaul history. He's one of the people on that. He has a lot of experience in the field. So take it away, Dr. Jason. The floor is yours. Do you want everybody to wait until the end to ask you questions?
I have all the questions. So what I can do is I can go through them, but they were excellent questions. And this is the introductory community psychology class at DePaul University, and Ted Bobak, the instructor. And we have terrific questions that you folks have posed to me. As I go through this, if there's anybody who has any particular question, just feel free to let me know and I can stop. But I really want to be able to get through these questions. They were so good. It says you cannot minimize Zoom when you're recording this session. Okay, so I need to, that's something I didn't realize. So, but I
should
have
be able to just drag it over. It won't minimize, but it'll drag the window over.
Yeah, great idea. Good, thank you. So Louis asked the question, and thank you, Louis, for your question. Can you explain what went into the process of community psychology emergence in the US in the 1960s? And I can also talk about, my interest as well in terms of just providing that. Certainly in the 1960s, the mid-1960s, you have what's called the Swampscott Conference, where a group of people get together and say, we want to do things a little bit differently as psychologists. Rather than waiting for people to come to our offices, we want to get more active. And there were lots of unrest in the country over civil rights, over the war in Vietnam, and many other different movements. And basically psychologists sort of said to themselves, is there a different approach that we had? Now, I didn't really know that there was a field of clinical community or community psychology when I applied to graduate school and got in 1971. But that was only really 6 years after the field got founded. And actually, when I was in graduate school, the two major journals just started getting published in 1973. So in the first annual review chapter of Psychology and Community Psych, Social and Community Interventions was being written by my advisor when I was in graduate school. So it was a very kind of exciting time. And I can tell you that I had always been interested in kind of more political issues of social change. And when I was even in junior high school, I worked for, I volunteered for a presidential campaign going back to Humphrey and Johnson, 1964. But what happened was when they did get elected, they got us into the Vietnam War, which I was very against in terms of the policies. And then I worked for, when I was in high school, a congressman who basically asked me, because I had done prior work, asked if I would head up Young Citizens for this congressman named Helstowski, and he got elected also, but then he got himself into all types of trouble and was investigated for a number of different scandals that occurred in the late 1960s. So my last kind of episode of work was trying to work on the Bobby Kennedy campaign, presidential campaign of 1968. And you all know what happened to Bobby Kennedy. He got assassinated. So these were just events that occurred that made me, I was interested in politics, I was interested in social change, but I just wasn't sure how to go about doing it. And my experiences doing these things were just not very successful. And I was kind of disappointed by some of the outcomes. So that's why I sort of gravitated towards psychology. And I just thought I'd be a traditional clinical psychologist, have my office and see patients. But when I went to University of Rochester in 1971, I had no idea that there was a field called community psychology. It was so new, but my advisor named Emery Cowan was one of the people who really began the field. During my first year, he gave a lecture in a class, and I'll never forget that lecture because he said in it that there's really a limited number of personnel who could be change agents of like therapists, and that there just weren't a lot of them, and the need for them was much greater than they could ever meet, and the demand, the need and demand were just very much greater than there could ever be those personnel. And the other finding that he mentioned that sort of surprised me was he said paraprofessionals probably could do just about as effective as professionals. So here I was in graduate school for 1 month, and he was telling me that as a paraprofessional, I could probably, which I was kind of a paraprofessional without a PhD or master's, I just had a BA, I might be as effective in my therapy outcomes as someone with a PhD. And, we talked about that. And part of the reason could have been that the young non-professional person with just maybe a BA or even less, maybe was more enthused and excited and rooting for the patient. And maybe the PhD after a while just didn't have the same energy and enthusiasm and care that they might be extending. So the results were ambivalent. It didn't seem like one group versus the other group were any more effective in treating a wide variety of different clinical problems. So I had my first identity crisis right at that point in the middle of the class, his lecture. And I'm saying to myself, what am I doing here? But then he said, there's new roles for psychologists. We could be doing something very different. We could be thinking about prevention rather than just treatment. We can be thinking about actually training up change agents, people who are supervised. We could supervise and train people who are undergraduates to implement interventions. So we could extend the reach of services. We could consult with natural change agents and grassroots groups. We could do more social policy type work too, of trying to make a difference. So when Emery Cowan talked about this, it really sort of energized me because those were really the things I wanted to do anyway. I wanted to be involved in more of I activism type part of psychology. I didn't know there one existed. So it was a perfect kind of, in a sense, confluence. I could become a psychologist, but I could be one that was focusing on community psych, clinical community psych. So it was a very kind of refreshing time for me. So that's just a little bit about myself and my background. And I think it typifies a lot of the people who kind of entered this field in the 70s, myself and many of my colleagues who were basically looking for a difference, trying to be more proactive and active and trying to think about how do we get there, not when people have serious problems and basically it might be more difficult to help them then, but get them earlier and maybe try to sort of nip the problem at the bud, which made a lot of sense to me. So Louis also kind of had a good question about there's many psychological experiments throughout the years, such as the Stanford Prison Experiment, to understand social behavior. And what Louis said was, has there been something in community psychology that could be also elevated to that level? And I think there are at the societal level, as well as even at the local level. And I keep saying the local level because it's important for us to think local, because that's what community psychology, I think, is about. If I were to think about the societal level, what really grabbed me as an experiment was something that George Fairweather, who was at Michigan State, did. and it was called the Lodge Experiments. And what he did was he had patients on psychiatric units kind of work together and actually become like a unit, very cohesive. And then when they got discharged, they all got discharged together into what's called a lodge, which was a community agency. It was really a place where they could live and they would get some supportive services. And when they basically got discharged together and they had those social support bonds, they were less likely to end up going back to the mental hospital. So I thought this made terrific sense. You know, why don't we help people in transitions from total institutions like mental hospitals and make their transition to the community something that is basically help those individuals have a greater chance of succeeding. I think this experiment is still extremely important. It was very carefully done. And it was probably something in the back of my mind when I started doing my own work with recovery homes, which I'll talk about a little bit later. At the local level, Louis, I think something that's that's very important is thinking about DePaul University, which you're all part of. And DePaul University really had a clinical program that started up in the 1960s. So we had a clinical program and we developed into a child and community program. So there's a clinical child and a clinical community PhD program. That's when I came in 1975 after I graduated. But what we did at DePaul, which I think really shows that we can take an institution that maybe isn't known for being, you know, like Harvard or Northwestern or, you know, with that type of academic status, and we could make this setting into something that's really outstanding and actually world famous. And that did occur over time, where we developed at DePaul University a community PhD program standalone to the clinical community program. That's one that Ted Bobak is part of. He's just finishing that program. We could also develop an undergraduate concentration in community psychology, which Olya Glansman, so many of you know her, has been instrumental in doing. We could also develop a master's program, which I'll talk about a little bit later, so a person could get a master's or even a 5-year degree, a BA, MS, or just a pure master's in community psych. So those programs that are occurring at DePaul provide us an infrastructure that is actually unparalleled. There's no institution in the United States or the world that has this amount of community psychology training. So we are actually known around the United States and the world for producing, you know, just a terrific set of courses, training experiences, and students who get this exposure that they really would have difficulty getting anywhere else. And that again shows how a setting can change and have programs develop where we can become the best. It doesn't matter where you are, what setting you're in. If you stick with it and you kind of stay with it long enough, you can actually help create incredible change that can become really inspiring for many people. All right, so thank you, Louis, for those questions. I'm going to now move on to Danielle. Is it Danielle or Daniela? Danielle. All
It's
right.
Danielle.
Danielle, okay, well, thank you, Danielle, for letting me know. So you asked, what are some trends or commonalities throughout your studies you find to be a hindrance in your research? And Louis also asked, what kind of community psych research goes into the idea of equal distribution of resources? And Mariella also asked, do you think community psychology is not as accepted in today's society because people think it's too much work in terms of secondary changes? And what does the application of community psychology flourish? And besides civil rights and areas where it doesn't work. So those are all good questions. So I'm going to put them all together. Excellent sort of analyses that you had. And I'm going to talk a little bit about what I see as sort of the biggest issues in the field. And that is, do we want to be involved in first order or second order change? And I think first order is really cosmetic, where you have kind of a bandage where you put over some type of cut, but it hasn't really taken care of the infection. Second order change is where you're trying to change the roles, trying to change the power structures, trying to give people who might be not have resources or power the opportunities to really change in a very meaningful way. It's not superficial. So second order change is fundamental. It's deep rooted. One way of thinking about that is, say someone is kind of at the beach and they're basically seeing someone that's struggling, trying to swim. Well, you can go out and save one person after another because in a sense, they might not have the swimming skills. You could say that's kind of first order change. It's important for us to help people. But what if we provided good swimming lessons to everybody so that they knew had the skills, so that didn't end up going into the deep parts of the water and getting themselves in trouble? That would be much more of a second order change, where we're giving them the skills before they have the opportunity to get themselves in harm's way. So second order change really involves how do we get to second order change? And I think this is the challenge that I tried to address in a book I wrote about a decade ago called Principles of Social Change. And I really said, if you want to do second order change, if you want to be involved in doing that, you have to recognize that basically there's going to be institutional barriers. There's going to be a lot of people who are going to probably try to stop you from doing that. Not because they're bad people, it's just they disagree with you and they want to stop your thoughts of reform. And I'll give you kind of an example. And it is daunting and it's discouraging. And I think kind of what happens often is that you get someone who's like really idealistic and wants to change the world. And then what happens is it doesn't turn out that way. They get lots of resistance and then they say, the heck with this, it's just too hard. And they kind of run to kind of a much safer profession or type of lifestyle. So I think that us understanding that if you really want to bring about substantial change, you have to do certain things, which we'll be talking about. But they have to be done in a way that basically is integrative and recognizes it's not going to be easy. And the only way you're really going to be able to do it is by not doing it as the Lone Ranger. You're going to have to do it, not just yourself, but you're going to have to do it with lots of collaborating settings and people who are working with you. Because the institutional basis of change is basically very tough and hard. And you as one individual are less likely to be successful if you just approach it yourself and not with a coalition or other individuals behind you. Let me give an example of some of the work I did for many years on minors' access to tobacco. I'm not sure if you know it, but tobacco is the leading cause of death in this country. Over 350,000 people, 1,000 people a day are dying of tobacco. So if we really want to think about prevention, getting people not to smoke is clearly something very important. So I spent a lot of my career on tobacco prevention. It just felt that was a good thing to work on. And what I found out is that a lot of my interventions initially were just going into schools and trying to teach kids social skills to refuse pressure to start smoking. But that was all individual based. And what happened was the kids in some of those schools in Chicago told me, well, you're telling us tobacco is bad, but why are all the merchants selling us tobacco? This was in the 1980s, 1970s. So we said, well, gee, do they do that? So we actually sent 12 and 13-year-olds into schools, into different stores in the area. And we found that the majority of stores actually sold the minors tobacco. So that was astounding. So we then switched our emphasis from the kids in the schools to saying, how do we get the merchants to stop selling minors tobacco? We actually worked with Woodridge, Illinois, and Woodridge called us up and heard about some of our research and said, well, merchants in Woodridge don't sell minors tobacco because it's against the law. So I said, well, would you like to test that out? And they said, okay. So the police department sent minors into the stores and found out that the majority of tobacco retailers did sell minors tobacco. These are very young minors. And we worked on this for several years, and but it was a very tough struggle. Right now, it's changed since it was in the early 1990s, but at the time, the Retailers Merchants Association and many people who sold tobacco liked the idea of selling minors tobacco because they got a lot of income that way. And when we worked with the city of Chicago to get merchants to stop selling minors tobacco, I remember there was a press conference after 2 years of working with the city, and we were going to basically say that, yeah, you can actually stop merchants from selling tobacco if you find them for doing it. So it's called compliance checks. You just send minors into the store and you basically get them to see if they'll sell. And if they sell, you give them a ticket, and that'll stop their behavior of the merchants selling tobacco. And that was actually pioneered in Woodridge, Illinois. Woodridge became the first city in the country to show that you could stop minors from getting tobacco by using these procedures. It's very, very important. So in terms of disappointing, here I was at a press conference telling them that we were going to make Chicago the first city in the country to stop minors from being able to get tobacco, with very dangerous substance. And we knew that thousands of kids started smoking each day. And part of it was because they had easy access to tobacco. And during the press conference, the mayor was going to, Mayor Daley at the time, was going to support us trying to have compliance checks of really checking on minors. If minors could get tobacco, to give them fines and to really set up this type of operation. But the mayor got persuaded by the Illinois Merchants Association and the governor to basically switch his position on this. And even though I had seen the speech that the mayor was going to give before the press conference, during the press conference, the mayor kind of changed his mind and said, we don't need to do these approaches. We can just educate the merchants, which actually doesn't work at all. So that was an example of basically me seeing that even though I really cared about trying to make tobacco very hard to get to minors, there were institutional factors, merchants, the state, politicians, who were going to undermine my efforts to bring about change. And that was disappointing. But the good thing is the work that we did with Woodridge and the police officer, Buzz Talbot, he became a national spokesman on this area because of our work, collaboration that we did. And ultimately, the US government ultimately required all the states to basically show how they were going to reduce underage tobacco sales. And that has occurred for the last almost 20 years. And right now, rates of tobacco sales to minors, because of the work we did in Woodridge, has become the model of what basically is done nationwide. So again, sometimes you might do something and have negative results, but if you basically stay with it long enough and get to the right access to the people who are even above, for example, the city and the state, you can then have them work with you as allies to bring about change. So Danielle also asked, what was most surprising an outcome of the research that stunned me? Well, one thing that stunned me was tobacco press conference, where basically what I was hoping for, which was to really make it very hard for minors to get tobacco, was undermined. But fortunately, we were able to change that. But another thing that happened when we published our research in American Journal of Public Health with what we did in Woodridge in 1990, the tobacco industry took those findings, which basically showed that you really need to get tough with merchants. And if you do it, and if you give fines for them selling minors tobacco, they'll stop doing it. But if you just basically tell them you're not supposed to do it and just do educational approaches, it doesn't work. So the tobacco industry took the findings that we published in a very major journal, and they basically said, Jason at DePaul University has found that you don't really need to use these types of consequences. All you have to do is use educational approaches. So I was amazed that basically, if you have these powerful invested groups, and at the time they were completely out of control, they will take any findings, they'll twist them to what they want to sort of makes their case better. And the ethics is a little bit questionable, certainly. So again, making me realize that when we're involved in this process of bringing about second order change to make it, for example, hard for youth to get tobacco, there are going to be consequences, and many organizations and institutions, from the mayor to the tobacco industry to many other people, who are going to be fighting you, and you have to stick with it long enough to basically make a difference. So that's what I learned, that in a sense, the consequences. And the other thing that so moving on from, I guess, tobacco, we can talk about how has having like chronic illness been an inspiration for research, and that it motivates you to keep going. And thank you, Danielle, for asking that question. So some of you probably know that when I was in my late 30s, when I was about 39 years of age, I ended up getting mono, and I really had a lot of secondary consequences to that. And I actually left the university for a year. And I had a lot of fatigue, and that got me interested in this illness called chronic fatigue syndrome, which we now call myalgic encephalomyelitis, or ME. Some people refer to as ME/CFS. And because I had been touched by the illness myself, when I came back and realized that there were a lot of people with this illness, I got interested in doing research on this. So sometimes when you're touched by something, could be something that's happened to you or a family member or friend, it might become a motivator. And I think that's very important, that the things that you pick to sort of work on should be things you really care about, not just for this 6 months or not just for this year, but something that you're willing to put a lot of time into. Because if you put a lot of time into something, you can become an expert and you become really able to make a contribution. Why? Because it often takes that amount of time to switch from first to second order change, and to sort of recognize all the institutional barriers, and to get people to mobilize yourself with to sort of defeat those barriers. But that takes time. And the only reason you'll stay with something long enough to really make a difference is if you really care about it so much that you're willing to work on it, even though you might not be successful for a long time. All right, I'm going to switch to Angelina. Angelina had a great question. What's some advice you would give for students that want to pursue a career in psychology? And the first one I would say is, again, having that passion for something. Stay with the topic for a long period of time. And the reason you'll stay with it is because it really means something to you. You might kind of want to change poverty, and there's nothing wrong with wanting to change poverty and giving people more access to resources so that there aren't such a difference between those who have and the have-nots. But to really do something like that, you have to really care about it and also stick with it, and also work with the community groups and organizations that can make a difference in bringing about change in there. So all those things have to come together. So it's not just having an interest, something you really care about, but also recognizing that something as difficult as poverty is probably going to take a long time to really bring about changes. And you don't want to just sort of try to do something and then say it's not going to work. You want to basically stick with it, whether it's homelessness or people who don't have a place to live with substance use disorders, or people who don't have high enough income to survive today's economy. Those things are all going to take a lot of time, And you're not going to be able to make those changes yourself, even though you personally might want to, but it's really sticking with it. That's the key, and actually mobilizing the forces that might make a difference with kind of having alliances with others. Okay, we also have from Angelina on the website, we have a study about brain fog during the pandemic. Can you talk a little bit about the findings? Well, it's very interesting that one of the classic features of the long haulers, those people who have COVID and haven't recovered, or those people who have ME, myalgic encephalomyelitis, is cognitive impairment. So an example is, they sort of take their keys, they get in the car, they drive somewhere, and they forget where they're going to be going. What were they doing? So, and again, it's like cognitive things don't work, and that makes it sometimes hard to come back to work because of the cognitive impairment. And sometimes we get change. It's very interesting that cognitive impairment, I think, is one of the key classifications for this illness called ME/CFS. And there was a kind of a group that was trying to bring about some type of change in terms of the case definition. And it turns out that I had an opportunity to be on that panel, which is called the Institute of Medicine. And this was in 2014, 2015. And, at the time, I didn't join that particular committee for a number of reasons. One being that they were talking about a clinical case definition. I thought they really needed to focus on a research one. But in retrospect, I kind of wish I had actually joined that committee, because that committee came up with case definitions that I think if I had been on that committee, I could have helped make some changes to make the definition even better, because that's what I've done a lot of work with, is kind of what is really needed in the case definition. So sometimes one has to make some type of concessions to be able to willing to work with others that might not be perfect in terms of what you think is important, but just be part of the process. And we do make mistakes. But again, it's a long-term process. Even though you might make a mistake sometime, you can kind of stick with it and try to make correction on that over time. What's your favorite and least favorite thing about my job? Well, Angelina, another excellent question. My favorite is seeing something new, the creative process. I think each of us kind of really gets excited when we can see something new happen for the first time. And that's exciting. As some of you might know, I have been studying recovery homes for a long time. There's over 250,000 people that are living in these recovery homes. And the ones I study, which are called Oxford houses, and Ted also studies, have, you can stay in as long as you want, as long as you pay your fair share. And there's no professionals, it's all self-help, self-run. So it's very exciting to sort of see something like this mature over time. And I've been working with this organization for about 30 years. And we just came up with the finding that we just published about a week and a half ago, where we said, we looked at the recovery homes and how many people had COVID and how many died from COVID from the start of it, March 2020 to last year, January at this time. And we actually found that even though people in these recovery homes are high risk, many of them have been homeless. The majority have had past criminal justice involvement, have been in jail or prison. Many have psychiatric comorbidity. They might have anxiety, depression, as well as substance use disorder. So they have a lot of risk factors. A lot of them have chronic illnesses that they incurred while they were doing substance use. But that group, when they lived in the recovery homes, had significantly less rates of becoming infected with COVID and significantly less mortality than the surrounding communities. So that was kind of a cool finding. And when we see something like that emerge, that really confirms the importance of having community-based settings like this. Well, that's really very exciting. Another very exciting part of my job is when I see like the institution of DePaul develop all these community psych programming for people like yourselves and others, undergraduate courses, graduate courses, a BA degree, a BA MS degree, an MS degree, a PhD, an MA PhD degree, to see all these degrees possible. And I had some role in sort of being there when these different programs get started. The Human Services Program, I helped start in 1980. Some of you probably have heard of that. The community psych sequence, I helped start that about almost 16 years ago. So again, those are really exciting things to sort of see the creation of a new setting or new opportunities that we provide undergraduates. I think the thing that's the least favorite part, and again, an excellent question, is sometimes the bureaucracy. You know, I think we're living in a society where there's silos. Each institution kind of sort of does its own thing. And different parts of institutions do their own thing. They often don't communicate with each other. So you've got everybody, in a sense, becoming very specialized and cautious. So you make a phone call to some service group, you know, you can't really get somebody on the phone. You get sort of explanations. So you often go to like 4 people before you even begin to get a solution to a problem. And that type of over specialization and lack of people that we call boundary spanners who can help you navigate through the silos occurs in the economy, occurs in academia. And I think that can be a very frustrating thing with the type of work that we do. All right. Thank you for those questions. Now, Isabel, you had some very good questions. So I'm going to put them all together into one big piece. I'm going to read it out, and then I'll kind of talk about a possible how I would respond to it. Isabel said, I generally do not know the answer. I appreciate the perspective as a psychologist. I noticed on your website, you talk about the importance of focusing on social justice as a community psychologist, citing disproportionate allocation of resources as a cause of social problems such as homelessness and poverty, which in turn cause mental health problems for those who experience them. I fully agree, which leads me to ask a couple of questions. Does this mean that community psychologists must therefore be involved in figuring out ways to end homelessness and poverty, the prevention of which would preemptively remove some of the worst stressors that exist in society today? How do we address the individual mental health of a client, that patient, when they are where they're victim of huge social problems that's not going to stop exploiting them without significant and immediate social change? So in that question, you really sort of went a lot of places. So I think there's a place for us trying to end homelessness, end poverty. It's going to take a long time, and it's going to be not something we do ourselves. We're going to have to partner up with lots of other people, organizations, institutions, alliances, as we basically try to defeat the forces that basically drive so many to, for example, homelessness. And truthfully, the reason that you have so much homelessness is that you don't have affordable housing. So it really gets back to housing, an issue. And for me, I've spent 30 years working with Oxford House, and they now have over 3,000 houses, kind of housing some of the most at-risk people. Probably 40,000 people in the last year have been in Oxford houses. That's a lot of people that have been helped to try to give them a chance. When you take a person who comes out of jail or prison and you ask them what they want a job and a safe place to live. A lot of them are in there because of substance use disorders. So the key is really saying, how do we work on things that are more systemic? Certainly, as a psychologist, we could help them with dealing with some of the trauma that they've endured while in prison or that got them into prison. But they need something very basic. If you kind of think of Maslow's hierarchy of needs, they need the basics, food and shelter. But we're psychologists, so we don't think of ourselves as working on things like food and shelter, but we can. And again, an example is, the Oxford House movement, which I got involved in and Ted got involved in, and we do evaluations and we do studies like the COVID study. And we basically constantly try to understand how it can help others. I don't know if you know, we've just completed a study with college students, Oxford houses on college campuses. That's kind of cool. So we have our first study of that that we just are publishing. And we also have looked at Oxford houses on Native American reservations, which again often have very high substance use rates. So we can make a difference, but even though we try to make a difference on housing stability, which is really a critical part of poverty, that doesn't necessarily mean that we don't care about individuals. I get phone calls constantly from people who are dealing with COVID-19 or who are dealing with MECFS. And I do a quick assessment on the telephone. I don't charge anything. And I try to help them sort of see kind of why some of their symptoms could be exaggerated by the challenges that they're faced with. So I might, in a very short time, help them maybe prioritize to maybe focus on one or two things, not 6 or 7 things, so that they have a chance of getting successes there, and also how to hook up with healthcare professionals so that they can get a multidisciplinary team to help them. So I can do that quickly because I'm an expert in that topic. I really know a lot about it, and I can kind of often, help people even on a one-to-one level to sort of be a little bit more able to cope with some of the issues that they deal with very devastating illness. So Isabel also asked, when do we address the client's mental health without changing the system? How do we avoid participating in and even acting as a normative force to support the things that are causing so many people so much distress? So again, very good question. And as I said, I do think that we can help individuals, we can help friends of ours, we can basically be, probably the most important thing in all these cases is to respect and listen and validate. Sometimes we might not even have a solution, but just being there to sort of say, we understand, and we're not going to kind of make you feel worse is very important. People with MECFS are constantly being victimized by the healthcare system because people think they're malingering, that they don't have a legitimate illness. So by someone like myself validating their experience, I get emails and calls from all around the world. Even this week, I got some people from Ireland who asked me if I would represent a girl who's 16, who's basically been put into a mental institution and basically taken her rights away. And they're asking if I will try to be available to talk to some of these people that are involved in this type of treatment, which isn't fair. And of course, I said, I'd be happy to help. So again, I can help an individual. I can help validate the illness experience. It's very hard to understand when a child's doing well academically and seems to be very popular, and then all of a sudden begins to isolate themselves because they're very sick. It's not because they don't care about all the things that a teenager would want to have with friends, popularity, opportunity to socialize. If they kind of retreat from all that stuff, it's got to be a pretty strong reason. And with MECFS, that means they're very sick. And that has to be appreciated. And if I can do something to help in that appreciation of, validating that particular illness, then that's a good thing to do. All right. Carolina has said, has the field of community psych changed over the years? Has any colleague of yours opposed these changes? And yes, there's, again, the field of community psych, kind of when I came into the field, was very much, I think, kind of clinical community. It sort of started out by saying, can we help people sort of in a sense by training up like paraprofessionals to go into mental hospitals and sort of help those individuals. But the people in mental hospitals need more than just someone that comes in and kind of talks to them and is supportive of them. The people in mental institutions need to be able to, as kind of Fairweather showed, have a place to transition into the community that's supportive. That's what's important. So I think the field initially was very kind of catch problems early or deal with people with severe problems with like paraprofessionals. And the field went from that to prevention. So as I kind of finished my training and came to DePaul, there were more people saying, how do we think about prevention? But at the time, prevention was thought of as probably a lot more, let's give the person's particular skills, like I was doing, going into high schools and junior high schools, teaching kids resistance skills so that they wouldn't succumb to smoking. So I think that was the next phase of going from helping high-risk people or people who had severe problems that were mental hospitals with having paraprofessionals, helpers, to, in a sense, dealing with prevention, trying to get there and stop them from, for example, starting to smoke to start with. But then the field has gone to another dimension of saying we need to understand the social context. So in my own work, I went from basically focusing on tobacco smokers to focusing on the social environment. How do we make sure social environments do not provide access to tobacco to these kids? And also my work with recovery homes, how do we basically find places where people can live and have all their needs met? You know, think about someone who is in an active addiction and is involved in criminal activity. They're probably going to lose a lot of their friends, or their friends that they continue to have are going to be people who are involved in substance use or illegal activities. And that will make it hard to kind of separate from that social network. Well, if you put that person into a network that's involving everyone who's working, no one's doing illegal drugs, and everyone who basically is paying their rent and is working to sort of change their life, just think about how that social network is a complete refresher for that individual. If we could think about psychotherapy as taking a person who's very disturbed and has all types of people around them that are not helping them into a completely different social environment, that would be great. Well, that's what social kind of work that's involving community psych in Oxford House is doing. It's taking people and putting them into a new environment, taking people who are in poverty, who have no resources and nothing, and putting them to a middle-class environment, a really nice looking house. Sometimes they have swimming pools, color TV. And then you kind of say to yourself, gee, maybe it's worth kind of joining, society and trying to get a job and trying to be different. You got to make it worth their while. And you can't, and that's why kind of thinking about something larger can have a very strong impact. And I can just think about, again, if I think about a challenge, when I came to DePaul, and I know racial justice is more and more important to all of you with things that happened with George Floyd and others over the last few years. When I came to DePaul, we were doing outreach in the psych department to Cabrini Green, which was then African-American, and it was not what it is today. And if you can believe it, we had no African-American faculty, we had no African-American graduate students, and we had no Latino graduate students. It was all white, it was primarily males. Well, if you get put into a system like that, you kind of say, something's wrong with that. I knew there was something wrong with that. And I went to the director of clinical training, who's a good friend of mine, and I said, we got to change this. We got to start, bringing more faculty on people of color, and we need to basically, bring some students in who are from different underrepresented groups. And they kind of looked at me like, I was really very strange for saying things like this. If you can imagine, this is like, if you can believe the world was once like this, it really was. But I just kept causing trouble. But, again, keeping sort of my position, keeping good terms with people, but raising issues. And for 6 years, I kept asking the same question. And eventually I had a Latino student who, actually the first Latino student was Josefina Alvarez and Joe Dante. And Josefina Alvarez, maybe Ted knows, but she came out of our program and then went to one of the PsyD programs and was a professor there for many years. And did terrific work. And so I was thinking to myself, I was in charge of psychi at the time. And I also had just started up the Human Services program in 1980. And one of my students was an African-American named Vicky. And she was president of psychi. And she said she would like to go into a clinical program, but it was so competitive and she didn't know if she could make it. And I said, well, I think you can. So we worked together and she put an application in and we worked on getting her into the program. And she was the first African-American that entered our clinical PhD program. And she did terrific. And she, later on in her career, she appeared on Oprah. And she's a very successful psychologist in Houston, Texas right now. But that was important to sort of break that kind of barrier that we had at DePaul. And I was very, very happy to be able to be someone who didn't think I could do it immediately. It took me 6 years of working on this and just kept working on it and thinking about ways. So sometimes you're going to be in a setting that has certain abuses or having things that you really feel bad about. And sometimes you're just going to have to wait for the right time. And what happened with the right time, which is kind of funny, is the director of clinical training, Jack Reisman, one day said to me, honey, if you think you can do better, you do my job. So I said, okay, I'll take over your job. So I became the director of clinical training. And when I became director of clinical training, I had more say as to who came into the program. So you see, sometimes you just have to kind of wait long enough to get that opening. And when you get that opening and you have that availability, you take advantage of it. And that's what I was able to do. All right, we're going to go on to Mariella. And Mariella asked, what types of careers are available for community psychology that is not academia research oriented? Well, that's what our two new MA programs are about, the BA/MA in community psych and the 2-year combined program in community psych, is really to prepare people for jobs in community psychology. Olya Glansman, as you know, is really the key person working on those two programs. And Olya, by the way, was a graduate of our own community program. She was in the second cohort at DePaul University. So you see, we kind of helped train someone, and now that person has come back, has helped create new programs. So that's very exciting to see. But in terms of, there's not an agency out there that can't use someone that has some experience with trauma. And we're really trying to focus on trauma in these two master's programs. And truthfully, if you have good skills that are helping to basically help people think about issues of prevention, issues of empowerment, issues of racial justice, issues of trauma, you have a role to play in just about every organization. And I would say even the police organization, even not-for-profits that deal with anti-violence crime, even school-based organizations, city-based organizations like the city of Chicago, or even the government dealing with Illinois state or the federal government. There's roles in all these different places for a person who has solid training that can think analytically, can answer questions, and has a perspective in community psychology that we've been talking about. So it's really something that provides you for a tremendous amount of social service agencies and not-for-profits are available for doing this type of work. All right, and Vito asked, what about the process of receiving funds? And how does that look like? Well, I can tell you that if you know how to do grant writing and you have some experience with that, which is a really good skill, every setting wants someone who can basically bring resources in. So if you get some training in writing grants, that's terrific. Or if you get opportunities to do it, take advantage of it. But sometimes writing grants is something that doesn't have immediate consequences. So as an example, our work with Oxford House, we started that in 1991. And we wrote grants to the federal government, to the state government, to try to get funding. And it took us, we just kept sending grants out. And the people who evaluated the grants kept saying, that's not going to work. That's not going to work. And I think we threatened them. The professionals who were kind of people who were primarily treatment providers in substance use settings basically said, well, gee, if we're saying that you can get all this help from recovery home and there's no professional staff, what does that do for me? So I think that was threatening. And so eventually what they said is they said, you have to do a randomized design. You have to have some people get Oxford House and some people don't from treatment setting, follow them over time. And that's the only thing that will support. Well, I said, you can't do that because basically Oxford Houses decide. They have a vote as to who to accept into the house. It's like a family. You can't just assign a person to a house. So I didn't think you could do that type of research. So I called the person who developed this organization called Paul Malloy. And I said, Paul, I don't think we're going to get funded. We have to do a randomized design. Have some people go to Oxford House, some people not, and then follow them. I don't think we can do it. So Paul said to me, look, I've been working with you for 8 years. We've been doing pilot work. I trust you. We'll make it work. So here the organization of a grassroots organization worked with me on a design, but we actually were able to make it work. We submitted the grant and we got it funded. What I didn't know, so sometimes you have to just hang in there long enough to sort of get the money so that you can do the research. And the research was important because it showed that Oxford House, if those people went at the Oxford House, they were twice as likely to have abstinence 2 years later than those who didn't. 70% positive outcomes versus 35%. So we really could say it really does make a difference. And that data was then used to go back to the federal government to make Oxford House classified as one of the empirically validated programs for substance use, which then gave them a lot of credibility, which helped them to expand their program. So the reason I say this, which is again such an interesting process, is when Paul Malloy said, yes, we're going to work with you, what I didn't realize was before I started working with Oxford House in 1989, someone approached the Oxford House organization outside of Washington, D.C. and said, I'd like you to do a randomized design to compare Oxford House versus not Oxford House. And Paul Malloy said, I don't know you. I'm not going to work with you, and cut off the relationship. Well, I didn't go to Paul Malloy saying this is what we're going to do. I went to Paul Malloy and his organization and said, let's get to know each other. And let's sort of slowly build up trust with each other. Let's do participatory research. What is it that you want? What is it that you need to have found out? And then we'll try to answer those questions. It's a very different style. And that's what community psychology is about. Community psychology is bringing the community in as equal participants. And if you do that, you're going to have much more opportunities, and they will then help you when you run into difficulties. All right. All I can say is these were terrific questions. And I thank you all for such a remarkable, thoughtful issues that you brought up. And I know I've been kind of talking a lot, and I've gone through a lot of different things. And I wanted to stop here and just kind of turn things back to Ted. If anybody has any kind of follow-up questions to me, I'm happy to try to answer them. But if not, that's okay. But I wanted to just give a little space here for you folks.
I was just going to say thank you for coming out and sharing all your experiences with us and answering the questions. And I like how we were talking the past week or so in class about some of the things you touched on, like the first and second order change. So it's always good to hear it again. And your beach example was great, just maybe teach them how to swim instead of sending them out into the world. So we really appreciate that. And if anybody has some questions, this will be the time to ask. If not, then if you do, this is a good time. But if not, then I think we could give a round of applause to Dr. Jason. I know he's kind of busy. So if you don't have anything, Dr. Jason, thank you for coming out and we appreciate your time.
Okay, thank you, and appreciate your participating in this exercise, and the questions were really excellent. So thank you all. It was really a delight to think about this and just think about how to answer these questions, because very thoughtful, and I can tell by now that we've got a whole class here of budding community psychologists. Bye now.
Take care, Dr. Jason.